just to summarize my own background, I'm a respiratory consultant. I did my doctoral thesis on innate immune responses to pathogen-associated molecular patterns and innate immune responses. So I studied a lot of cytokines. In fact, I worked in the lab just above Dr. Liam Fanning, so nice to see him again here as well. And I would have trained in transplant and respiratory, and I would have been involved with a lot of the people that are involved in the COVID response, meaning I trained in ICU and anesthetics, and I also used to be the vice president of the Consultants Association, so I knew a lot of the media and politicians through that. So on the 5th of March, there was a group of us kind of pushing to get early lockdown, and the purpose of the first lockdown was twofold. One was to avoid healthcare decimation, and the other was to see if we could achieve elimination nationally. Now, we were a little bit concerned at some of the things that were being said at the time as to what the plan was. And bear in mind, 5th of March was before Paddy's Day had even been cancelled. And we'd seen that in Italy, they'd had their first case in around the end of January. And in a 5-week period, they were triaging 60-year-olds to come into ICU. And at the time, we didn't know that Bergamo had 57% of its population infected in a 5-week period. So we didn't quite know what the IFR for COVID was. So I set about setting up a WhatsApp group that got a fair bit of media attention. So I had the Minister for Health's mobile number. I had we essentially got a cross-party WhatsApp group. So we got representatives from Sinn Féin, Fianna Fáil, Fine Gael, meaning Simon Harris is in there, Stephen Donnelly was in there from the get-go, the Taoiseach Micheál Martin was in there, and for a period of time there was a few other people there, such as Tony Houlihan, and we had about 20 journalists and about 150 consultants nationally. And what I did for the first 50 people entering the group, I made them all admins so that they could add people of seniority that could get information out rapidly and that would have useful things to say about COVID, meaning we got the kind of directors of things like GP Buddy, Pharma Buddy, who would be able to get information out to 4,000 GPs and 4,000 pharmacists rapidly, as well as getting the heads of all the major organizations medically, so the heads of the ICGP, the heads of the IHCA, the heads of the ICU Society, the ID Society. We got a lot of researchers involved. And then, as I say, we have about 20 journalists in the WhatsApp group. Now, there was a large number of interesting people added to the group over time. There was most of the people you will have recognized from the Zero COVID group on the telly, Thomas Ryan, Professor Killeen, Professor Luke O'Neill, and a lot of other people that you'll kind of recognize from the media. So they were all added to the group. Now, some other interesting people were Dr. Ida Milne. Ida, you may or may not have come across, but she did her PhD on the 1918 pandemic and influenza, and she has given us a lot of insight into how the response was back in 1918, both the societal, the socio-economic, and even the resistance to masks and the debates about masks at the time. And we seem to have faced similar issues. Other interesting people in the group would include Professor Mary Horgan and Professor Paddy Mallon. And Professor Paddy Mallon actually and I have been liaising in the background on a few projects. And one of the people we liaised with was a Dr. Paul O'Brien. Now, Paul I'd never met before, but he actually is a man from Cork. And he was added to the group by one of the GPs, Dr. Nick Flynn and Dr. Donald Hearn. And he actually went to med school in China, did his internship in China, and actually worked in healthcare procurement between China and Ireland. So actually what ended up happening was we coordinated a conference between the universities and representatives from each of the medical schools in Ireland with the Chinese medical institutes over in Wuhan. And actually the Taoiseach Micheál Martin attended on behalf of the government. And essentially I didn't quite realize societally in China, but when you have one representative or level at one level in one country, the equivalent level has to go over there. So the conference we organized in China ended up being front page news to 120 million Chinese and was covered by 9 TV channels. So after that, we ended up doing the same documentary on RTE. So we followed that up with another podcast, which Dr. Paul O'Brien, Professor Mary Horgan, and myself attended and did a conference call with David McCullough to the Chinese. And we got advice on how the Chinese managed COVID early on in March. So the first 2 weeks in March, the Chinese were sharing information on steroids, innate immune responses, and actually strategies for managing your hospitals and reducing outbreaks in your hospitals. And Professor Horgan actually invited me to give an RCPI masterclass so that this information could be shared with the hospitals throughout Ireland. Now, a few other interesting people in that group. One would be Susan Mitchell, who's now become one of the senior advisors to the current Minister, Stephen Donnelly. One of the other interesting people I kind of came across in my career is a guy by the name of Professor Didier Cernet. Now, many mightn't recognize Didier Cernet's name, and I'm trying to get him on to prime time so that I can get his information out there. But Didier Cernet is the Professor of Complex Prediction Modeling over in the University of ETH in Zurich. He's also the head of the Swiss Financial Institute. And I first met Didier when we collaborated on a project. He does a TED Talk on predicting economic collapses, and he's developed a whole branch of complex prediction modeling known as Dragon Kings. And I'll explain the difference in a while between Dragon Kings and Black Swans, but Professor Cernet developed a whole branch of prediction modeling by the name of Dragon Kings. And previously, we collaborated on a project on using his prediction modeling system to work out the time for transplant in cystic fibrosis patients. And Didier is now one of the leads over in Switzerland, predicting both the economic and the societal and the mortality costs associated with COVID. In fact, one of the things he's working on is the cost per quality adjusted life year lost and the economic impacts that COVID is going to have. If you're interested afterwards, I would encourage you to look up a debate between Talib and Professor Cernet. And Talib coined a term by the name of black swans. A black swan event is an apparent, sudden, severe, catastrophic event that disrupts an entire society. And what a very good example Talib gives is you can't always model a system based on all previous data if you don't understand the interplay of the systems at play. And what this means is he gives an example of taking 1,000 turkeys, and if you ask 1,000 turkeys what they're going to do tomorrow, they're going to say, I'm going to get up, I'm going to eat breakfast, I'm going to eat lunch, and I'm going to eat dinner, and I'm going to do that for the next 365 days. Now, if you look statistically, it'll look like 1,000 turkeys giving it 1,000 or 365 responses of the exact same event happening the exact same day. Makes you think that a random event doesn't happen, but come Christmas Day, the turkeys have something else in store for them. So the point of a black swan is for the turkey, this is an unpredictable event, but for the butcher who understands the system at play, this is not a black swan event. Societally, we probably understood that COVID and that a pandemic was going to happen. We didn't understand how to prepare for it. We probably were underprepared, and it results in decision inertia when society is underprepared. I won't go further into that. Hopefully we'll get Didier Cernet onto the Irish media in the coming weeks, and if we do, then you might get some of his viewpoints on it, but I would encourage you to read any of his research on Dragon Kings. A Dragon King essentially says that most events besides pandemics have a leading up to it, and what he says is that you can predict a lot of things, but that you need to understand that the interplay of the events leading up to something. So he says that you get incremental changes leading up to a catastrophic event, where if you understand the greater system, you will be able to predict the consequences. And I think that's what's starting to happen in Ireland at the moment. At the moment, we're starting to borrow 20 billion this year, 20 billion next year. And what I've been kind of campaigning about at the moment is we need proportional attribution of resources so that the adequate amount of money and resources is put into key areas. One of the things Ireland has been poor at is describing their overall strategy. There's three main strategies in dealing with COVID. There's elimination, there's suppression or mitigation. New Zealand successfully chose elimination. China successfully chose elimination. There's a lot of countries successfully doing suppression and doing it on a much better level than Ireland is doing it at. Ireland had two good opportunities for achieving elimination. It could have locked down on the 5th of March, as many people in the background had been pushing for. It could have continued the restriction after the first lockdown in around July. At the time, bear in mind, there was about 10 counties where there was 0 COVID cases. And a bit like New Zealand, if you don't let somebody into an area, you won't get ongoing COVID in that area. So restricting inter-county movement was one of the most successful things we have done as a nation, and actually restricting distance that you can travel from your house, obviously within the kind of absolutely necessary journeys requirements, has been quite successful. I suppose one of the things coming out of COVID is we're going to understand a lot more about political leadership, and we're going to understand a lot more about governance, meaning the virus is unforgiving. It doesn't care what you think. It doesn't care about your anti-protest rallies. It is going to continue spreading in those environments. So the virus is unforgiving. It doesn't matter what Trump says. It doesn't matter what Boris Johnson says. It doesn't matter if they say that they're being successful. The data is the data. The mortality is the mortality, and the excess death rate is the excess death rate. So, you know, we all as a society have to learn to follow the rules, but similarly, we need guidance at a national level, and it needs to be vocalized by the leaders as to what that plan is. Now, I suppose one of the things we've been coming across in the media recently is the difference between the NPHET, National Public Health Emergency Team, and the government response to COVID. NPHET's duty is to look after the public health. The government's duty is to look after public health, society, welfare, livelihoods. And I think this is starting to play out in the media a bit more recently in terms of NPHET saying go to level 5, the government saying let's go to level 3 and let's go to level 3 plus or level 4. We haven't vocalized from the get-go what our strategy is. It's very easy to have a strategy, but if it's not vocalized, you end up with scenarios where we seem to be at the moment. I think Ireland's at a crossroads again. I think people have underestimated the speed at which the second apparent wave, if you want to call it a wave, is coming at us. Personally, I don't even like the term wave, but it is a good analogy. It's only a wave because it's controllable. Lockdown makes the wave, but you can easily achieve elimination after a lockdown, or you can decide that you're going to go for maximal suppression, in which case you do proportional allocation of resources. You don't increase your public health capacity by 5 or 10%, you increase it 10 or 20 fold. I suppose the last part I kind of mentioned in terms of kind of my interesting involvement in COVID is collaboration and research. I think one thing Ireland has been very successful for is we all know many other people working in other industries, and this is where Ireland can try and get a foothold long term to maintain its society. Ireland is very colloquial. We know a lot of people working in a lot of different industries. I've been lucky to be involved in a few projects where Tyndall and a number of colleagues from Flex and UCC have been very successful at developing a few projects which are going on in the background, meaning kind of non-invasive ventilation hoods, mask products. And when we all know each other, meaning politicians knowing academics, knowing medics, knowing people that have backgrounds in supply chains and production chains, it should be better that we can achieve successful collaboration. I think it's been very good. Medically, the amount of collaboration going on in the background. I saw yesterday two of my respiratory colleagues up in Dublin have been collaborating with Harvard in terms of predicting innate immune responses and actually looking at interleukin-6 to interleukin-10 levels as a predictor of mortality. Similarly, a number of other respiratory colleagues like Professor Richard Costo has developed an app for predicting mortality. So I think we've got a lot of know-how. I think we've been very successful in a lot of areas. I mean, the COVID app, which has been adapted in many other countries, has been very successful in Ireland, but we need to continue adding to that, and hopefully then we may have a more successful long-term strategy. I do think we need a 3, 5, and 7-year plan, and at the moment I think we're taking it month by month. So that's where I'm pushing at the background at the moment, is to vocalize the longer term plan. But at the moment I think we're in for a rough 2 or 3 months coming up ahead. I'll pass you back to Adina now.
Perfect. Thank you so much, Oisin. That was an absolutely brilliant and very informative speech. If anyone has any questions, please feel free to type them into the chat. But I'll start off with the first one, if you wouldn't mind, Oisin.
Yep.
So I suppose going into the second wave, or so as we'll call it, do you feel that we are more prepared to tackle it more efficiently this time around, or what do you think about that?
I think there's been a better societal understanding of the virus. There's better prediction, there's been better PPEs, and there's better supply chains, there's better testing and tracing. I think what's happened is we've got complacent. I think at the start, people used to tell me that this is a marathon, not a sprint. And actually, I was the other way around. I was saying at the very start, it was a sprint. If you achieve early lockdown, we could have achieved elimination. Bear in mind, New Zealand locked down the 5th of March, same time a number of us contacted the ministers and head politicians. So you know, we could have achieved elimination earlier on. I think at the moment we are underprepared in terms of bed capacity. We're underprepared in terms of ICU capacity. And I think we are facing a situation doing transient lockdowns, or whatever you want to call it, circuit breakers, for the foreseeable number of months, because we didn't adequately increase the bed capacity and we didn't actually have a long-term plan. There was a lot of healthcare professionals came back to answer Ireland's call, and they didn't get jobs and they've moved on. And similarly, I can guarantee you, I know a lot of junior doctors and nurses that are intending moving away next year because the working conditions frontline are extremely tough in Ireland. And I think as a consequence of that, this is what I'm talking about, proportional allocation of resources. If you don't make working conditions as good as they can be and should be, and make it an enjoyable place to work, then you will lose your healthcare professionals, morale will be low, and it will cause a vicious cycle where we will be forced to do ongoing lockdowns, and that has a bigger socio-economic impact than needs to be there, you know?
Absolutely, absolutely. Thank you for that. And you're absolutely right. And I suppose one final thing before we go on to our next speaker is, from your personal experience and your involvement, what would be the main message you would want the general public to be informed of going forward, that we can do now, the actions that we can take now?
I think people just need to understand that it's people move the virus. Yeah. And unfortunately, we are a very sociable society, which is good for having the crack. But we have to learn to adapt ways to live, to be sociable without being a risk. I mean, Zoom parties has become a thing. Actually, having a pint over Zoom doesn't infect anyone. Stuff that we would never have thought of before, just to reinvent how society interacts until there is a vaccine, or until there is a more successful longer-term strategy and more successful therapies.
Perfect, perfect. Thank you so much for that. That's brilliant. So if that's all right, we will go on to our next speaker. That'll be Dr. Liam Fanning, if he'd be prepared to present.
I think there are questions for him.
Oh, absolutely phenomenal. Thank you, Joan. I actually didn't notice them. Now, Oisin, can you access the questions yourself, or would you like me to read them out to you?
Would you mind reading them out? Actually, sorry, it's on the phone, and I'd say I could.
That's absolutely no problem. So one of our questions comes from Kira Gavin, and she's asking, do you feel we have enough information to plan for the next 3, 5 to 7 years?
I suppose this is where I'm saying, actually, I mean, I managed to meet the Taoiseach about 2 weeks ago, and I was suggesting that we get Professor Didier Sornet, and no more than we've created a health committee, I think we need to create an economics committee, a research committee, we need other committees which have got cross-party agreement, who've got a remit for looking at economy, looking at innovation, and looking at healthcare. And we need international experts with prediction modeling experiencing that understand the complex interplay. You know, I'm a medic, I understand a lot of the medical interplay. I don't understand the relationship between currency, stock, shares, equities, what the impact of this has on the economy. I do know that we are borrowing an enormous amount of money, as is a lot of other countries doing quantitative easing. This is where the likes of Professor Sornet, who is a world expert on complex prediction modeling, who is a world expert on economics, as well as presenting at the Royal College of Physicians, who knows all the global data extremely well on COVID, because he literally wrote a paper on prediction modeling in COVID, which for any of you interested, I'd encourage you to also look up, is his prediction modeling on COVID, and actually the responses, which he graded into 4 main geographical areas and how they've done different approaches. And he has highlighted that Asia has got this much better than the rest of the world in general in terms of their response. And also in terms of their government policy, their ability to move resources in China was extremely successful in their ability to achieve elimination.
Wonderful, wonderful. That's brilliant. Thank you. Our second question is from Shia Fergini, and she states that the numbers today have been 1,200. Do you think we should go now to level 5? And if so, how long would that be necessary to get back control?
As regards level 5, I think we're in trouble healthcare-wise. We're starting to see it on the front line that the difficulty is, I've heard many people that don't quite understand the interplay saying, oh, the mortality is low, maybe the virus is mutated. The virus has not mutated this quickly. It has not changed its mortality. All that's happening at the moment is there is a lag period between the mortality, because it takes 14 days on average to end up in ICU, and then the average stay in ICU before you define whether you live or die is 14 days. So essentially there's a 28-day lag in what is an exponential curve, and we are starting to see that exponential curve. So I see where NPHET had come from. I also see where the government are in terms of livelihoods. This is my point, is we haven't declared what our long-term national strategy is. And when we don't declare a strategy, things seem to creep up on you. But actually, this was entirely predictable. And if you had said, right, 3 months ago, 4 months ago, if you declared what the national strategy was, you could have prepared your healthcare system. And I don't necessarily even mean, like, at the moment, we're facing a situation where elective coronary artery bypass grafts, lung transplants, heart transplants, liver transplants, lung cancer resections are going to be cancelled because we don't have the ICU bed capacity in this country. And this was entirely predictable 3 months ago. And we should have made modular beds in ICUs so that we could continue running a elective service in addition to having the capacity to deal with your COVID incidental findings. but we should also have done a much more aggressive proportional allocation into suppression. So I suppose I'm not coming down either way in terms of the level 5, but what I am coming down on is we need to be vocalizing what the strategy is so that we can adequately resource that, because what seems to have happened is the second wave seems to have taken a lot of people by surprise when it was entirely predictable.
Yeah, that's absolutely true. Absolutely true. Our next question is coming in from Dr. Liam Fanning, actually, and it says, can you ask Oisin about the excess non-COVID collateral deaths?
So I suppose one of the things is like, in terms of the understanding now, again, so just to give a general picture, for every one death over 75, for every 14 deaths over 75, there's one death under 40, and 6 deaths between the age of kind of 45 and 70 approximately. The average length of life loss per COVID death currently is 12 years. Now, this is also one of those things where some people can talk about ageism. I suppose this is a huge thing in terms of how a drug is paid for in this country. Is they work out the cost per quality adjusted life year. In Ireland, it is 35,000 euros per quality adjusted life year. That's what decides if a chemotherapy drug is given in Ireland. That's what describes any drug that increased life expectancy in Ireland is approved if it comes under approximately 35,000 euros per quality adjusted life year added. I suppose what we're facing at the moment is we know the number of life years lost per COVID death, it's 12. We're starting to realize the economic and societal impact. I think we have to be clear and we have to be open that in the absence of global elimination, in the absence of a vaccine which is unlikely to stop the pandemic, it's going to reduce mortality, it's going to reduce ICU stays. Yes, you can buy time by maximally suppressing this and having stronger suppression regimes, but we have to be open. There is going to be thousands of deaths in Ireland. Again, different people have quoted different IFRs. One thing I say, if you talk about an IFR of 0.5, it sounds low. But if you were told you're getting on a plane today and there's 200 people getting on the plane and one person's getting kicked off mid-flight, you're probably not going to get on that plane. So an IFR of 0.5 is still significant. Now, there's variations in the IFR. Some people are quoting 0.3, some people are quoting 1.0. I think that's got a number of factors. That relates to the demographics of your population, that relates to the BMI of your population, it relates to ethnicity, and it relates to innate immune profiles. One of the things Professor Sarnet did point out is historically, Western countries like Europe have invested heavily in prolonging longevity, and that the median life expectancy in European countries is around 82. That is higher than a lot of other countries. And actually, one of the things Professor Sarnet points out is you should actually benchmark geographically the number of life years lost per geographical area, bearing in mind that other countries have not invested as heavily in increasing the supports and allocations long-term to increasing the life expectancy of that country. So certain other countries, South America, does not have a median life expectancy of 82. Therefore, the number of life years lost is different in a society down in South America as it is in Western Europe.
Of course, of course. The next question that we have is actually a very, very interesting one. Any idea what the predictive modeling is suggesting for the so-called second wave and how this will impact the healthcare system?
That's a great question. I suppose we talk about the R0 value, and we talk about R0 refers to the number of people that one person infects. Back in February, we knew that the R0 coming out of China was around 4.0. Professor Nolan found that the R0 in Ireland in March was 3.8, and that had a doubling time of every 3 days. Realistically, we've created a 5-tier system, And we know that the doubling time in level 2 was every 14 days. Professor Nolan's data showed that if the R0 was 1.2 in July, that 3 months later, we would peak at 5,000 new cases per day. An R0 of 1.2 means that for every 5 people with COVID, 4 of them infects 1 person, 1 of them infects 2 people. So if the R0 is 1.2, that's what it means. So realistically, what we are trying to achieve is an R0 below 1.0, and that's essentially what we should be quoting when we talk about levels 1 to 5. You should talk about what is the R0 at level 2. We know it's about roughly 1.2, and it's a doubling time of every 14 days. And once it's at 1.2, you're peaking at 5,000 cases a day at whatever duration down the line. Realistically, what we're doing at the moment is we're varying the level 3 and the level 4 and the level 5 because we have such low healthcare bed capacity in this country. So it doesn't really matter what prediction modeling says at any given time point. Realistically, what you have to do is adapt to know what the R0 is and what the duration of the doubling time is. But once it's above 1.0, you inevitably overwhelm your healthcare capacity. So you have to achieve an R0 below or equal to 1.0, where 1 COVID person infects 1 other, and that's it.
Mm-hmm. That's brilliant. Thank you. And I suppose that stems beautifully into our final question for yourself, sent in by Joan, who's asking, do you think we would achieve elimination soon?
I don't think the government has the initiative to achieve elimination. I think we could have done it if there had been a stronger initiative in March and July. I think NPHET have publicly said at this stage they're not going to do it. I think similarly, I don't think we can be successful with elimination unless we can get agreement with Northern Ireland and the UK. And I don't think Boris Johnson as a leader has the ability to actually even contemplate something so complex.
That's perfect. Thank you.